So this is an exciting time. We have more data, we have more science than we've ever had about the effectiveness of substance use disorder treatment. And there is an opportunity now to take what we have learned in the Surgeon General's report to the mainstream of America. So Tom, you've been a great champion of integration of behavioral health services, of looking across the continuum of care. Can you tell me what is the difference and what is similar between treating substance use disorders and other chronic diseases?
So that's an important question. For decades, probably centuries, addiction's been conceptualized as a character disorder, personality disorder. And you had to tear that personality down in a program and build it back up, reconstruct it. And it often worked. But now, as was shown much earlier today, it's quite clear that once you're addicted, you've got a brain illness that will go on long after you stop the drug use. In turn, you're going to need the kind of continuing care that other chronic illnesses have. And it doesn't mean, very importantly, it doesn't mean just doing the same thing for a longer period of time. That is not chronic care. Chronic care is the kind of care that you get with diabetes, where you proactively are screened if you show early signs of a problem, that you and your family are given information and advice and counsel, that where you need it, medications are available, diet, behavioral change strategies are all there, along with monitoring for the duration of the time that you have the illness, which could be forever. So that's the vision that we see. And very importantly, this isn't just a gift, an important gift, to people who've long suffered from addiction. This is a gift to the rest of medicine. It was said better by the Institute of Medicine than we said it in the report. They said in 2006, it's not possible to deliver safe or effective care for general medicine without simultaneous consideration of mental and substance use problems. It's time and it's possible.
So, Dr. Clark, you are the editor of the treatment chapter, and in these last months, days, we've been talking a lot about increasing access to medication-assisted treatment. Can you help us understand why doesn't everyone get medication-assisted treatment now that we have them available, or should everybody get medication-assisted treatment?
At this point in time, there are medications for opioid use disorders, and there are medications for alcohol use disorders. There are no medications per se for things like marijuana use disorders, hallucinogen use disorders, and et cetera. So with those two groups with the most research, we need the kind of findings that we're getting from the NIAAA and NIDA in order for us to facilitate a greater availability. We also need to work with communities. We need to work with recovery organizations and peer groups so that where medications work and fit, as Mr. Levinson pointed out in terms of practice-based evidence, we need to be able to embrace that. And a comprehensive strategy acknowledges that some people benefit directly from what you could call anti-substance use medications, but they may need other medications because let's not forget trauma, co-occurring disorders, physical health disorders, so they may require other health-related medications that would benefit them so that their recovery can be facilitated. As Tom was pointing out, having medications a part of a comprehensive strategy allows both the patient and the practitioner to consider the best approach to deal with recovery. And as Mr. Levinson's pointing out, having benchmarks to provide feedback through motivational interviewing or other strategies so that the patient knows what he or she is doing, what progress they are making, and so they can reflect on what it is that they need to do, and families involved in that also. So we're dealing with a lot of transformation of attitudes and beliefs. As Tom pointed out, there was a while where if you were in certain types of recovery programs, you did not take medications even though it was indicated. This is an opportunity for a sea change in attitudes.
That's great, yeah. I think it's important for consumers and families to know what the range of options are, and then to the degree we have better data, we have better tools, and we put those in the hands of patients, they can also make better choices. And they can also track their progress and decide what is the right path for recovery for me, because I'm informed by my own data. So I think that's very exciting. So what about those consumers, those folks who might look at the report and say there aren't a lot of evidence-based practices which have been normed on subpopulations? So by gender, by racial or ethnic population, by sexual minority status. What do we say to folks who might come from a subpopulation or may identify with a subpopulation for which there isn't a strong evidence base?
That's an important question, because evidence-based practices have been questioned from that basis. If it hasn't been normed on young African Americans, does it mean it will apply to them? And the answer is, we think so. There's no reason to believe that the medications, that the services, that the therapies that have been shown to be effective with the same level of evidence that is used today to approve medications, randomized controlled trials, there's no reason to believe that they won't work. Yet, that research hasn't been done, and until that's done, we won't be fully certain of it. And it's, as Wesley says, it is likely that groups with special characteristics, regardless of what those characteristics are, will have special needs in addition. So it's a damn good place to start with evidence-based practices and go from there rather than some kind of ideology. And so that's what we're recommending.
But with integrated treatment and monitoring, we will be able to refine our efforts. I know a lot of people have benefited from the existing traditional model, even though it has its limitations. With better data, we will be able to refine that. And we'll be able to get both the NIH and SAMHSA and HRSA involved in helping us characterize the unique needs of special populations. So whether you're a senior citizen like me, or you are a woman, or a member of the LGBT community, or someone with physical or intellectual limitations, we will be able to refine that. And it's those kind of data and that capability that we need to have, both for community-based organizations as well as large university organizations. We'll be able to accomplish that.
I think that what we're trying to say is that there is no fixed treatment architecture that we're after as a solution. I think that the answer is, a living treatment architecture that's constantly learning from its own outcome, as well as the research that is coming from the bench. And as those are joined together, put through our clinical intuition, integrated into our architecture, watched, we look at the outcomes, and then we loop that back and we calibrate care again. Treatment, ultimately, I think the best we can do is to not become meiotic. I think meiosis is the enemy of recovery. It's the enemy of our progress.
In the rest of healthcare, that's called personalized medicine. And there's no reason that we can't have personalized care in addiction.
And shared decision-making. We want to make sure that the individual who has the problem is benefiting from the intervention. We want peers and individuals to be actively engaged in this process.
Thank you very much. All right.